Screening, which sort of comes at the beginning but fits in any time, and we all need to think about it. I also realized I've got some slides in this presentation that will answer some of the questions that were raised yesterday about added value of screening. Disclosure is here. Now, one of the ways that I got interested in the value of screening and outcomes was that I was asked to give a talk a number of years ago, 1994, in Canada, in London, Ontario. Those of you in the audience who have been around for a while may remember that London, Ontario was one of the major centers in the 70s and 80s for fetal physiology research. They had a sheep lab and did tremendous work in helping us understand fetal physiology. So I was really honored and humbled, and it was a big deal to be invited there for me. And a few weeks before the presentation, my administrative assistant came into my office and said they just called and they want to know what your presentation is going to be. And I said very confidently, fetal echocardiography makes a difference. That was my title. So then I went to give my talk, and I walked into the hospital, and there were posters all over the hospital advertising my talk. Aside from how right, pay no attention to the picture. It's the title is the thing. And I looked at it and I said, wow, how do we know? Because when I got home, I looked, and there really wasn't much research on outcomes. Now, there's a lot of stuff has been done on outcomes since then, but it really made me start thinking about, how do we know? If you look in the fetal anomaly literature, there's remarkably little about whether kids do better with our prenatal diagnoses. So, talk about screening a little bit. I don't think we've gone over these kinds of statistics in this course, but this is why you're all here, is because it's important to identify these kids. There's a lot of effort, a lot of fundraising and publicity around causes of infant mortality, including prematurity and low birth weight and the maternal complications and SIDS, and these are all important things, but congenital anomalies actually results in more deaths. And this data from CDC counts deaths between 20 weeks of gestation and 1 year after birth. It's not a standard definition. If any of you are MFM fellows, you're going to take the boards. This is not the definition of perinatal mortality or infant mortality, but it was what CDC looked at. Congenital anomalies was the number one cause of deaths. And within congenital anomalies, over a quarter of the deaths were due to cardiovascular disease. So, again, that's why you're here. I know I'm preaching to the choir. You all know that this is important. Not going to go through the full fetal echo views. We've got numerous talks on different parts of the heart. I'm going to talk about 4-chamber anatomy and screening in the first and second trimesters. So there are 10 things listed here as the components of the deceptively simple-sounding 4-chamber view. And this may get to why our statistics are so lousy on screening, because it's not just counting to 4. We have to be sure that we know where the heart is, that it's on the left side, that the atria are the right sizes, the ventricles. We should identify actively the left atrium with the foramina valle, the apical offset of the tricuspid valve, the septum being intact, and that may take several different angles to be sure. The presence of a moderator band to identify the right ventricle. The axis is important, and the heart should occupy about 1/3 of the chest. And the easy way I don't measure the size. I learned from Kathy Reed from Tucson. Just look at the chest and ask yourself, can I put 2 more hearts in there? And you'll get a sense. So the screening less than 14 weeks, important to use a high-frequency transducer. It's important to use vaginal scanning liberally, which gives you even higher frequency transducers and gets you closer to the fetus, and can be very useful in the 14, 15 week time. But keep in mind, you got to have both approaches available. The range of motion of the transducer is limited with vaginal sonography, and we have to manage patient expectations that we may not see everything. Those are the rules to keep in mind, and the approach, make sure you establish the situs, and that's especially important with a vaginal scan. Right? We're all used to situs on the abdominal scan. With the vaginal scan, you really have to be sure you know where the head is, where the spine is to get the situs correctly. And once you have, as Alfred was describing yesterday, if you start with the abdominal circumference and sweep up, you should be able to go through the standard planes. Color definitely helps. Important to have the right settings, that is, to keep the acoustic output as low as reasonably achievable, that it definitely goes higher. The smaller your color area, the more concentrated the energy is. And I think it's also important to keep in mind that it does not replace a later scan for high-risk groups. And I've got some statistics on that in a moment. So here we've got a 12-week scan, came in for a nuchal translucency screening. And I think it's clear that we've got a problem here. We've got a very big right atrium and a much smaller left side. And I think this is the same fetus, yes, with showing the high degree of tricuspid regurgitation that's causing the enlargement of the right atrium. And this was a tricuspid valve dysplasia. What else do you notice about these pictures besides the heart? Why do we think about the heart only occupying a third of the chest? If the heart's big and the ribs are fixed, something else has to be small, right? The lungs are small. So at 14 weeks, this was about 14 weeks, we already have small lungs on this kid. So that tells us a lot about prognosis. Screening is definitely going to vary. The outcome of our screening is definitely going to vary with maternal BMI. The higher BMI, the less likely we are to get a successful screening in the first trimester, and this just shows some data based on BMI 30 to 39.9 and greater than 40, showing that there were many more successful first trimester scans, 10% more successful in that lower BMI group and then in the higher BMI group. And it took, particularly in the high BMI group, it took 2 exams to be able to see things. When we screen in the second trimester, as we were bemoaning yesterday, and I think we all share the same opinion, we're not as good as we should be. This is composite data from studies from the US, Europe, and Israel, looking at outcomes of screening studies. And screening studies, they're hard to do now, right? They're hard to do. So the composite of these, over 100,000 fetuses, was that about a third of the cases of heart disease were uncovered. Why is a screening study hard to do now, a 4-chamber screening study? Well, how many people here don't include the outflow tracts in their screening study? None of you. Okay. If I ask you to do a randomized trial where half the patients are going to have a 4-chamber view only and half are going to have a 4-chamber view plus outflow tracts, how many of you think that you could, in good conscience and honestly, participate in that study? Nobody, right? So that's why these data are old. Now that we've added the outflow tracts, I think even if you felt that there was equipoise and you could ethically do the study, I think it would be really hard not to do that just slight movement of your hand. It doesn't take much to get the outflow tracts once you know how to do it. So that's why the data are old. My approach in talking to a general audience of sonographers and sonologists is to use the simple rules for screening. Okay, aside from those 10 components, what are the simple rules to keep in mind to do your screening successfully? Well, the first rule is ask yourself, is something too big? Similar to the prior case. Is something too big? Yeah, it's the right atrium. Now, in fact, this one is another Epstein malformation. You can see the tricuspid valve there. But just from the right atrium being large, I don't know yet what's wrong. It's a screening study. This needs a fetal echo, right? Right atrium can be big because of tricuspid valve dysplasia, Epstein or non-Epstein. It can be enlarged because of severe pulmonary stenosis with an intact septum and regurgitation. It can be big because the left is too small. We don't know that yet. Something's too big. And then the other question to ask is whether something's too small. In fact, these are flip sides of the same coin, right? If one thing is, as Jack was talking about yesterday, if one thing's big, and the other side's going to be small, and vice versa. So here we have a very small left ventricle. We have several other things going on with the outflow tracts, but a small left ventricle and an enlarged right ventricle, but the problem there is the small left ventricle. Something could be in the wrong place. This is the first picture in all of our scans that we do at Yale. Okay, is this, for the sonographers here, does everybody do this as a first picture? Right, this is your situs picture. Not to mention, as an obstetrician, it's my picture that shows me that the placenta isn't down there. So this is my situs picture. Lower uterine segment, they label it first picture. So when I'm reviewing images, I always know the situs of the baby. So same baby, and we've got our lower uterine segment picture, and what do we see on this picture? If it's a vertex and the spine is here, what side of the baby is this? Right side. It's okay if you have to do a little body thing. I can't do, there's a thing with the thumbs that I can't do. I'm always twisting my body around. Right, so we've got the stomach down here on the right, and then we've got a sweep starting with the stomach and moving up, and we see that the heart is also on the right. So we have situs inversus, everything's on the wrong side, and in fact, I believe this one had a normal heart. It can happen with a structurally normal heart, but it needs an echo. You have to be sure that everything's normal, including the venous return. One other thing that was in the wrong place, this one's pretty obvious, very early scan with total ectopia cordis. We can also have a situation of something doesn't belong here. This one doesn't want to play. Let's see. There we go. Right? These tumors don't belong here. And there could also be masses in the chest that are pushing the heart around as something that doesn't belong here. And if you're in a, this is where, of course, obstetricians, MFM imaging is important because we're looking at the rest of the baby, but I assume all the cardiologists here are comfortable identifying diaphragmatic hernia and lung masses that can be pushing the heart around. Cardiac axis is important to keep in mind. And easy, simple rules should be 45 degrees plus or minus 15, so 30 to 60 degrees. And it's increased in abnormals, especially of the outflow tracts. We saw that in one of the cases yesterday. Also increased with ventral wall defects for some reason. So again, have to look at the rest of the baby. I almost never use the protractor function on the machines that allows you to measure angles. I got tired of using those in high school. But generally, you can tell by looking, right? If we look at that four-chamber view, the angle is more towards 90 degrees. Now, there are outflow tracts abnormalities for sure, but just focus on the four-chamber view. It's pointing almost at 90 degrees. Here's another one where the four-chamber view, really not bad except for the angle, and in fact, this was a fetus with transposition with an intact septum. This one, the cardiac axis is shifted to the right to my eye, and in fact, the angle was a little on the low side, but I said I almost never use this particular function on the machine. In fact, that's totally in the wrong direction, right? If that's the septum, let's go back. Right, if that's the midline, that heart is pushed way over to the right. Now, the heart could be shifted to the right because there's a cardiac abnormality with situs ambiguus, the heart's in the middle. It could be pushed to the right because there's a diaphragmatic hernia or because of a malformation, a cystic adenomatoid malformation of the lung. I still use the old terminology. It could be shifted to the right because there's agenesis of part of the right lung. There are a lot of different reasons that we have to sort out. And then another thing in terms of the simple rules is something is not right, from Madeline. And I think if you look at this heart, particularly the color pictures on the right, something's not right about that heart, right? The right ventricle looks strange. Some fibroelastosis, looks thickened, still has blood flowing in and out of it, but something's not right. We have to sort out what it is. So the more recent data, when people have looked, there's a bunch of studies, and I'm not going to quote them all, that suggests that we should be better than we are. And a lot of these are retrospective studies that take numbers of babies with congenital heart disease. This one from Utah is pretty big. They would have expected 64% to be found with an abnormal outflow tracts, and they would have expected to miss about 40%, so find 60% with poor chamber view. But in fact, the real detection rate was a third. And I'll confess that there were a couple of MFM people who I think I examined or tortured or somehow in Texas a few years ago here. My thesis for my MFM boards was on the four-chamber view. And it said that I think it was 85% detection rate of congenital heart disease. The highly scientific assay that we used was Charlie Kleinman, who had the best eyes of anybody created in looking at hearts. Charlie Kleinman looking at babies with known abnormalities and saying whether or not the four-chamber view was abnormal. Wasn't really good data. I don't think I would have accepted it now for a thesis. So we all think that we should be better than we are. And this gets to the added value of fetal echo. Of course, it depends who's doing the scans. So this was a paper in circulation imaging that looked at almost 700,000 pregnancies. 1564 had severe congenital heart disease. In these authors' hands, about 2/3 was detected before the fetal echo by scanning, and they moved that needle from 65.4%. They moved it up by another 3% with the addition of fetal echo. So they went from 65 to 68% detection with fetal echo. And there were still a third of cases that got missed. Is that important? Well, for the 3% that were detected, it may have been important if those were significant cases of congenital heart disease. They also did an interesting calculation, basically number needed to test. So for all fetal echo indications, they would have needed to do 28 fetal echoes to find one case of congenital heart disease. In other words, about 4% of the cases that came in, they found congenital heart disease. It's just another way of expressing that number before. And 1 in 28 is a higher rate. Well, I guess if it's 3%, that's about the rate that we were quoting for a prior child with congenital heart disease, right? So in the same ballpark. So that would make it sound like it's valuable. But when they looked at, that was all indications, when they looked by indication, if there was a normal ultrasound, you can see the numbers got pretty big. They were calculating that between roughly about 1 in 250 would be the detection rate of congenital heart disease, that they'd need to do 250 scans to find one case of congenital heart disease, and even more for maternal medications, but that's going to vary a lot by the medications, as we talked about yesterday, and how much folate people are exposed to. So suggesting that the yield is low after a normal scan, but it's not zero, and if we have these known indications, makes me reluctant to abandon the fetal echo. I think there's still value to the more detailed look. So we talked about risk factors yesterday, and that screens work in low-risk groups where moderate sensitivity is acceptable because we can't do fetal echo on everyone. My business manager would love it if we did fetal echo on everyone. I'm sure all of us would enjoy that. But we don't have, realistically, we don't have the people power to do it. Plus, it would not be a reasonable use of healthcare dollars because of the yield. But in higher risk groups, we should be doing it because of the higher prevalence. We already talked about risk factors. In a moment on does it matter? This is some combined data on postnatal outcomes in the same unit with and without prenatal detection of heart disease. And the pooled analysis odds ratio was it was 20.25. So there was a tremendous advantage to prenatal diagnosis. The mortality that they found in this study was about a quarter of the postnatally detected cases, which is pretty dramatic. So I think, yes, it matters. And of course, you all know that. That's why you're here. And so we've got a common cause of morbidity and mortality, lots of risk factors. As I said yesterday, if you just go by family history, you're not going to find the vast majority of cases of heart disease. We have to be looking for it in everyone. And that's it. We can make a difference. We just have to keep working at it. Thank you.